Chief complaint. This is a 79-year-old male who was referred for an oral sleep appliance because of the inability to tolerate CPAP. He wears a chin strap while using the CPAP to keep his mouth closed. His past medical history is positive for coronary artery disease, 8 coronary artery stents, obstructive sleep apnea, severe arthritis in the knees, gout, psoriasis, osteoporosis, periodic limb movement syndrome, prostate cancer, pneumonia, hiatal hernia. He has a recent history of ear pressure, tinnitus, and sinus problems as well. Allergies to Riopro and heparin. His current medications include simvastatin, ramipril, ropinirole, metoprolol, Plavix, nitrostat, various vitamins, and baby aspirin. Again, surgeries include 8 coronary stents that were placed. He has a family history of cancer, and social history, he does grind his teeth. For the extraoral exam, when palpating the craniofacial muscles, he did have some mild pain on right-left masseter and right-left posterior temporalis. The palpation of the temporomandibular joint was normal. He had normal assessment of facial jaw and occlusal structures, a normal opening of 60 millimeters, a right-left lateral of 10 millimeters, and a good protrusive of 15 millimeters. He had a slight right-left TMJ crepitation when moving jaws side to side. The inspection of his teeth, alveolar, and gingival tissues were all normal. Tooth contact was also normal, with no contact between 7 and 10, which is again very normal. He did have moderate attrition, anterior-posterior teeth. And the patient has a 2-month history of pain on tooth number 14, which he is planned for extraction next month. He states he does not want an implant. The panoramic film was normal. You do see a slight periapical lesion on 14. In the periapical view of tooth number 14, the radiograph here is more clear. You do see the radiolucency, and this is the tooth that's planned for extraction. In this case, the diagnosis was severe obstructive sleep apnea, and he also has some localized myalgia. For the treatment plan, I plan to fabricate an oral sleep appliance. I discussed with the patient the success rate, the risk, the maintenance of the appliance. The consent was signed and impressions were taken. I reviewed the daily exercises for the patient. Patient was advised to still use his chin strap with the oral appliance to keep his mouth closed. I recommended a follow-up sleep study at the conclusion of the titration of the appliance. At the follow-up visit, this patient states that he feels he has less daytime sleepiness since he's been wearing the appliance. His wife was with him, and she said that he's snoring less. The patient is overall happy with the results of the appliance thus far. So patient is aware of future polysomnogram to evaluate the effectiveness of the oral sleep appliance. So what is obstructive sleep apnea? So this is the complete closure of the airway, and it occurs when the muscle tone of the body ordinarily relaxes during sleep, and at the level of the throat, the human airway is composed of collapsible walls of soft tissue, which can obstruct the breathing during sleep. In these obstructive sleep apnea patients, they have a characteristic snoring pattern which consists of loud snores or brief gasps of air that alternate with the episodes of silence that usually last about 20 to 30 seconds. And you can see here in the picture how the soft tissue has collapsed and the air, which is in the color of blue, actually can't get through to the patient's lungs. So the standard treatment would be CPAP, that is the gold standard. However, there are many patients who cannot tolerate the CPAP for various reasons. So what do we do for these patients? Well, we have the dental device, which looks like, in this picture here, a modified herpes appliance. And the idea with this appliance is that we're bringing the mandible forward in the hopes that we're allowing more room for the airway to open for the air to go through. And you can see in this picture that the air is now moving down toward the lungs. The results from the original sleep study from this patient showed the apnea, which we already discussed, the apnea-hypopnea index, the AHI. We discussed apnea, but hypopnea is a 50% decrease in airflow for at least 10 seconds, followed by an arousal and or 3% oxygen desaturation. So they have the apnea-hypopnea index for this patient was 64.6 events per hour, which is quite high and in the severe range. And RDI, the respiratory disturbances, was 98.7 events per hour. Respiratory disturbances were associated with oxygen desaturation down to a nadir of 75% during sleep. The mean oxygen saturation during the study was 94%. The cumulative time under 88% oxygen saturation was 5 minutes. And we really don't want their saturation to drop below 90%. So, what does the literature say about treating obstructive sleep apnea with an oral appliance in severe cases? Because remember, the gold standard is CPAP. But we do have many patients who have severe sleep apnea who cannot tolerate CPAP. So, oral appliances for treating severe sleep apnea are recommended for patients who have failed to comply with the CPAP treatment. The objective of this particular study was to evaluate the medium long-term outcome and success rates of oral appliances in patients with severe sleep apnea. So this was a retrospective study, 52 OSA patients with the apnea-hypopnea index of greater than 40, and as you remember, our patient was 64, who did not tolerate CPAP treatment. They were enrolled and fitted for a modified herpes appliance, which I showed you a couple slides ago. A 2-year mean follow-up included a second polysomnogram conducted in 36 of the patients. So for the results, a significant reduction in the AHI was demonstrated between the initial somnogram of 55.25 and follow-up exam after wearing the appliance and titrated to 17.74. So they concluded the oral appliances were found to be successful in treating severe sleep apnea after first-line treatment of CPAP had failed.